Thank you, Raju. Great talk, and especially the last part was very interesting. I'm sure we'll have questions about that later. Our second speaker is going to carry through and elaborate with recent updates on some of the things you talked about with regard to polypectomy. Our next speaker, Sonia Reicher, is a clinical professor at UCLA and chief of the Division of GI at UCLA Harbor. She is also the co-founder of the Association of Women Endoscopists, and it's a pleasure to have her here today.
Thank you very much. It's a true honor to be here and participate in this amazing course that I've started attending as a fellow few years back. Let's see. Oops. These are my disclosures. And it's a hallmark of a superb teacher like Dr. Raju to outline and present complex concept in very clear and concise way. So my plan today is just to highlight that concepts that have been so superbly presented to you already. So when we're facing the lesion, we want to find it first, assess whether we can do it or not. And then if we decide to resect it, try to figure out how we're going to resect it. And then, is there anything we could do to decrease risk of complications? Think about how we can manage early cancers, and then manage the recurrences that we probably would have to face at some point, as well as talk about the training. But before I start, I want to remind everybody that we do have a problem. And this is the first abstract highlights this problem. And this comes from Australian group. And the main message of this study, at the surgery for non-malignant colorectal polyps is very common. And most of these lesions can be removed endoscopically. And they looked at all the admissions for surgery in New South Wales for about a decade. And they linked their Australian ICD-9 and ICD codes. As you already see on the graph, there is across the board, various facility settings, there is a high number of surgeries being performed for non-malignant colorectal polyps. And that has changed over the decade. So about 11% of these surgeries were performed for non-malignant polyps. And here's a staggering statistics. There was a 4.7% rate of 30-day mortality after this surgery. To me, it was kind of staggering. And almost 16% rate of major adverse events. And this patient stayed in the hospital with no adverse events for almost a week, which is kind of crazy, and much longer if they had complications. Now, not surprisingly, having sicker patients or needing a rectal surgery was associated with high risk of complications. Now, we do want to remove the polyps, but first of all, we have to find them. And one of the challenging ones to find are sessile serrated lesions. And we've known for a while that these are challenging, and these are the lesions most likely to contribute to development of interval cancers. And this particular abstract looks at a very large hospital-based system, had a 55 gastroenterologists involved in the system. And the question that they asked is, what is the rate of sessile serrated lesion detections? Because the data on that is limited. And they looked at more than 10,000 colonoscopies and looked at their sessile serrated lesion detection rate. And again, as you could see on the graph, there's been significant variability along various settings in the sessile serrated lesion detection rates. Overall, the benchmark rate that they thought should be around 9% is more common in men than in women. And they found significant variability was ranging between 1% to 19% between various physicians. But overall, the academic practice tend to have high rate of sessile serrated lesion detection. Now, after we found the lesion, the question is whether should we attempt to remove them endoscopically or should we not? And we in our program and everybody else teach our fellows to use the Japan NBI expert team classification to help us guide those in those decisions, whether it's EMR or ESD or surgery. And this is a study that was somewhat disappointing with the results. I put out the slide here to remind you what the JNET classification is, and it's mainly focusing on the difference between type 2A and 2B, with 2B showing this irregular caliber vessel pattern as well as irregular surface pattern, suggesting that these are the lesions that should be attempted to remove with ESD. And the group here in this abstract from the single center, it's a single center prospective observational study looking at the large lesions more than 20 millimeters over a roughly 5-year period, looked at diagnostic accuracy of JNET, and they actually compared and said, well, if in addition to JNET, we can include acid factors like having a macronodule, having a Paris depressed area 2C, as well as having a non-granular morphology, would that help us in diagnostic accuracy of JNET? And as you can see, JNET performed rather poorly. Let's call it for what it is. High-grade dysplasia versus submucosal invasive cancer, sensitivity is 46%. The high-grade dysplasia versus superficial submucosal invasive cancer, again, 67%. The disconnect classification with addition to factors that I mentioned does improve sensitivity, and that was statistically different, statistically significant, but still comes at a price of significantly decreased specificity. So just keep in mind, if you are evaluating this lesion and you're trying to rely on all these factors, these schematas are not great. So we talked about that the risk that we should be trying to remove these polyps ourselves. We identify those lesions. We decided based on whichever schemata that we use that we're going to do it. The next question is how we're going to do it. And we'll learn in the recent years with the cold revolution that not using electrocautery significantly decreases the risk of adverse events that are associated with the use of electrocautery. But should we use cold EMR for large colorectal polyps? And this is one study. It is a large multi-center prospective randomized trial. There were actually, when I was reviewing the abstracts, there were a number of others with similar results. But this I thought was one of the more well-done studies. And as I mentioned, it's 10 centers in North America. Over the 4 years, looked at large non-pedunculated colonic polyps. 2 groups, patients were randomized, no use of electrocautery, cold EMR, with electrocautery, hot EMR, and in the hot EMR group, there was a thermal ablation of margins and defect closure as indicated. And their primary outcome was a serious adverse events. And since they did anticipate that it was going to be a certain rate of crossover, they actually anticipated around 10%. They also did a per protocol analysis, and patients were followed until their first surveillance colonoscopy at around 6 months. So as you can see, they had 660 patients that were randomized. At the time of DDW, 78% completed their first surveillance colonoscopy. And on the per protocol analysis, not particularly surprising, the rate of adverse events in the cold group was significantly lower. On intentional treat analysis, it was no different. And all major complications were in the hot group, the perforations, the bleedings, and the difference was 1.4% versus almost 5%. Now, everything in life comes at a price, and this is the sign of what the price is going to be for using only cold EMR. We definitely win on the risk of significant side effects, but the recurrence rate in the cold group was significantly higher. And particularly, the recurrence rate was higher in the lesions that had high-grade dysplasia, 46% versus 18%. One important point, the good news for sessile serrated lesions, there was no difference. Now, we talked about a potential approach to resection. Now, is there anything we could do to decrease the risk of complications? And one of them is evaluation, and very meticulous and detailed evaluation of post-resection defect. And Australian group brought to us the Sydney deep mural injury classification, and this abstract looks at consistent use of it and management of deep mural injuries in accordance to the schemata. And I want to remind you of what it is, where type 3, where there is a injury to the muscle layer, and I put a picture that injury actually could be visible on the resected specimen, might be more difficult to see in the defect. So you should examine the specimen that you took out as well. And the Australian group looked at their very meticulous protocol that they use for many years to see if that decreases the rate of delayed perforation. And they do have a very bold title. It said that their approach is actually eliminates delayed perforation. Well, it didn't completely eliminate it. There was 2 cases of delayed perforation, but they were actually, both of those cases were in the group that they did not think had a deep mural injury. They said that both cases, one was done at ileocecal valve and having a fat content precluded adequate visualization, and the other one, there wasn't any injury, but as they tried to close the defect, one clip perforated the muscularis propria and caused the delayed perforation. But overall, the risk of delayed perforation was very low, was less than 0.2% with this meticulous approach. Finally, is there anything we could do for really early colorectal cancers? And it's always challenging to think of sending the patient to surgery for these early lesions. And this study, it's data from very large European prospective registry of full thickness endoscopic resection using full thickness resection device. And I put a picture of it. That's how it looks after the lesion is resected. And they looked over an 8-year period of their results with a full thickness resection of early cancers. I want to remind you that they considered high-risk lesions, lesions with lymphovascular invasion, high grade of tumor budding, poor differentiation, or inadequate resection margins. And they, at least the initial results are somewhat encouraging. They had a 94% R0 resection rate. The 3-year survival was 98% of those patients that didn't have high-risk features. Even the ones that did have high-risk features, the 3-year overall survival was 83%, and the rate of recurrence was low. So this is something to be considered. Again, I want to caution that there's still, the follow-up is only 3 years, so it's something to be determined. Now, we all faced with recurrences. Dr. Raju showed a beautiful way of managing. This is another one for using underwater resection techniques, and this is from single center, high level center retrospective data on using underwater EMR as a salvage, looking at more than 350 patients for large lesions. Average size was almost 27 millimeters. And they were able to achieve technical success in more than 95% of the time. I do want to point out that 3 patients did require surgery due to perforation. The rate of recurrence was about 6%. But these are very challenging lesions that they managed. Now, finally, looking at, I was talking to our fellows, and I have a very relatively short career, but a lot of things that we're using in day-to-day practice, I was never taught in my fellowship. So we all need to look in the training, and we have to do better with training. This is a multi-center trial looking at setting minimal standards for training in colorectal mucosal resection, looking at 22 advanced trainees from 16 centers, and using a previously validated tool, which is EMR ST, I guess it's called. And you could see I put up in the slide of sort of summary of cognitive and technical skills with which those fellows were judged by. What was surprising to me a bit is that, and one has to ask, were the judges are a little harsh on that assessment? Only 40%, 41 and 33 trainees achieved competence in polyp morphology assessment and vascular pattern assessment, even less. 27% and 14 achieved competence in submucosal injection. Only 50% overall performed 19 EMRs during their training, which was the minimal number for assessment and position. So to be determined. But finally, and this is my last abstract, and I wanted to finish sort of on a good note. Overall, we're doing better with endoscopic mucosal resection, and this is a single center observational study. And they divided their experience in a contemporary one in the past 5 years or so, and the one before 2017. And they looked at all their experience with large lesions, and there was significantly less recurrence rate, 2.5 versus 8.9. There was significantly higher rate of end block resection. And then we're using more ESD, at least this group is. And then when they looked at, on multivariate analysis, the factors that were independently associated with recurrence and residual adenoma, in the contemporary cohort, the only factor was difficult to access lesion. Basically, if they got there, they removed it successfully. So we should have a small pat in the back for ourselves and say we're doing better. To summarize our sort of take-home points from this 9 abstracts, Still want to remind everyone that there is still excessive number of surgeries that are performed for non-malignant colorectal polyps. The mortality rate of 4.7% is really unacceptable, and we can do it. Now, sessile serrated lesions remain a challenge. The benchmark overall detection rate is about 8.8%. So take a look as what you do at home. JNET is not performing too well, so don't rely on it too much. And then if you're planning to use cold snare polypectomy, you will have less side effects, but it comes at a price of a higher rate of recurrence, and it's very important for patients to be followed closely. The consistent use of Sydney deep mural injury classification helps to alleviate delayed perforations. And then full thickness resection could be considered for small colorectal lesions, but it's still so far only data is 3 years out. And then more training is needed. And then overall, we're doing better with our ability to resect the lesions. Thank you so much.